What's up, Ninja Nerds? In this video today, we're going to be talking about GI bleed. That includes both upper GI bleed and lower GI bleed. So let's talk a little bit about the pathophysiology behind GI bleeds, and I think this really helps to delineate the difference, particularly between upper and lower GI bleeds. The first thing that you want to do is you actually kind of want to look at there's the structure here that goes from the crust of the diaphragm, and it actually goes down to this area, the duodenojejunal flexure. And this structure here is called the ligament of Treitz. And it's this anatomical structure that separates the, we'll say, GI bleeds into above the ligament of Treitz as more what we refer to as upper GI bleeds. And so this is really going to be bleeds that are originating from the esophagus, the stomach, and the first part of the duodenum. In this scenario, whenever patients have bleeding here, the blood actually does get oxidized, and it's also easy for the blood to be vomited out. And so they can present in two particular ways for upper GI bleeds. One is they can present with vomiting of blood, hematemesis, and the other one is they can present with a darkish appearing blood, kind of bloody stools, which we refer to as melena. Again, it's going to be more indicative of an upper GI bleed. For the lower GI bleed, we would say that anything below the ligament of Treitz, right? So we're talking about the jejunum, the ileum, the ascending colon, the transverse colon, the descending colon, the sigmoid, the rectum, the anus. All of this is going to be considered a lower GI bleed. And in these patients, the blood isn't being oxidized, usually by some of the hydrochloric acid in the stomach and the small intestine. So because of that, it's not going to come as a really darkish appearing stool. It's going to be more bright. And so we call this hematochezia, or bright red blood per rectum in these particular scenarios. So again, that's really how we use the anatomy to define the differences in what we refer to as upper and lower GI bleeds. Let's now talk about the upper GI bleed, which are, again, the bleeds above the ligament of Treitz. What we'll do is think about this pathophysiologically and anatomically. So again, we said bleeding above the ligament of Treitz would be the esophagus, the stomach, and the duodenum. What if I focus first on the esophagus? So the bleeding is originating in the esophagus, and it's kind of leaking into the lumen of the esophagus and moving its way down the GIT. Well, there's a couple different reasons. One of the first ones that you really should think about in a patient who comes in with hematemesis and a history of cirrhosis is esophageal varices. This is usually in a patient with cirrhosis who has underlying portal hypertension. The blood is backing up via the portal veins into the gastric veins and distending these kind of nasty esophageal veins. They kind of become very bulbous, very varicosities there, and sometimes they can easily rupture and cause massive hematemesis, melena, and even hypotension via hypovolemic shock. So that's one really big thing to be able to recognize. The next one is a patient who comes in with an underlying history of vomiting and retching. Maybe they were out in a bender, maybe they have underlying anorexia, or they have bulimia, and they've been having intense vomiting enough to cause these big longitudinal tears within the wall of the esophagus, and that's causing their bleeding. Another one could be underlying esophagitis. You want to think about price, and this is the kind of different types of esophagitis. Is it pill-induced esophagitis? Is it reflux esophagitis? Is it infectious esophagitis? Is it caustic esophagitis, or is it eosinophilic esophagitis? And in these particular scenarios, the patient may come in with an underlying history that would suggest that this is being esophagitis as the cause of their upper GI bleed. The next one's malignancy. Really think about a patient who comes in with hematemesis or melena with a history of a lot of weight loss inadvertently, and maybe even a little bit of iron deficiency anemia at baseline. You really want to think about malignancy as the potential cause, especially like an esophageal adenocarcinoma. All right, what if we go below the ligament of Treitz and we get past the esophagus and we get into the stomach? Well, in the stomach, there's a couple things that actually can cause GI bleeding and bleed right into the GI lumen. One would be gastritis. This would be if you have some type of like gastritis injury. This could be from NSAIDs, this could be from alcohol use, this could be from H. pylori. And sometimes even Curling's or Cushing's ulcers. The other one is it could be peptic ulcer disease, and this is usually in the form of H. pylori or gastrinomas, particularly Zollinger-Ellison syndrome. And again, think about NSAIDs, think about H. pylori, particularly in the history. Have they been treated for H. pylori in the past? Are they taking a lot of NSAIDs? These definitely may make you think about that. Another reason, again, with these patients is that if you really zoom in, let's say that I zoomed into the stomach lining and I looked at the mucosa, sometimes they can have these weird anomalies. It's kind of just an anatomical variant where they have a very shallow mucosal artery that sometimes this thing just literally starts actively squirting blood into the GI lumen, particularly in the stomach lumen. And this is called a de la Foy's lesion. And again, this is really important to remember. It can be a cause of intermittent GI bleeds. So sometimes the patient, if you have an intermittent GI bleed where they have melena, they stop, they have melena, they stop, it could be this intermittent bleeding of this shallow mucosal artery. So again, big thing to remember. The next one could be malignancy. And again, I would think about this in a patient who has an underlying history of inadvertent weight loss and some iron deficiency anemia at baseline. Now we move past the stomach, again above the ligament of Treitz, and we're still at the duodenum. And the duodenum, the most common thing would be a peptic ulcer disease. So again, an ulcer usually in the proximal portion here. So think about, again, that NSAIDs history, the H. pylori, maybe even the Zollinger-Ellison syndrome as the gastronoma potentially kind of caused there. And again, that's a really big one. The last one, super terrifying, super scary, but usually if a patient has a recent aortic surgery, like an aortic graft or some sort, they've had repair of the aorta, and now they're presenting with a massive melena, and on top of that, really bad anemia, I would really think about an aortoenteric fistula, that they probably fistulized between this aortic aneurysm repair and the duodenum, and they're bleeding massively into their duodenum. Now, with that being said, in patients who have upper GI bleeds, the most common manifestations, again, really important to remember, is hematemesis and melena. Again, darkening of the stools and vomiting up of blood. We now move into the categories of lower GI bleed. Again, so this is below the ligament of Treitz. In this particular scenario, I want you to think about lower GI bleeds in a couple different ways. All right, we go below the ligament of Treitz, but let's start at the large intestine. So we're going to go here, and we're going to think about, because there's not many things that actually cause this in the jejunum and the ileum, so we're going to go right to the large intestine. The big one is IBD. So inflammatory bowel disease, and the more particular type that is important to remember, is the one that really confines itself to the colon. And this is called ulcerative colitis. You really want to think about a patient who has underlying history of hematochezia, so bright red blood kind of per rectum. They have a kind of a baseline left lower quadrant pain during a flare-up, and they have tenesmus, which is the sensation that they have to go to the bathroom. They feel like the only way that they can relieve their pain is by going to the bathroom. And so there's this sense of urgency and the need to go to defecate to relieve some of that pain. The next thing I want you guys to think about here is an AVM. So these are very interesting. They usually occur more in the ascending colon, whereas IBD is going to be more in the descending portion of the colon. So usually it's going to be more confined to the sigmoid, usually starts at the rectum, sigmoid, up the ascending, maybe goes into the transverse. If it's going all the way over, it's pancolitis, but that's not super common. But in patients who have AVMs, arteriovenous malformations, there are these weird little connections between the artery and the vein and the actual portion of the ascending colon. And so sometimes these things can easily bleed. But I think it's important to remember, usually this is associated with patients who have underlying aortic stenosis and chronic kidney disease. Again, more ascending colon, more descending colon. The next thing is diverticulosis. This is actually going to be by far one of the most common causes of lower GI bleed, whereas the most common cause of an upper GI bleed is usually peptic ulcer disease, either in the stomach or in the duodenum. Now, in patients who have diverticulosis, they basically have these big stretched out diverticuli, and what happens is it stretches and shears some of the arteries with inside of that diverticula and then bleeds right into the lumen. So this is a really, really important one. Sometimes they'll be completely asymptomatic or have a history of diverticulosis. The last one's malignancy. So this is usually a patient with underlying colorectal cancer that's invaded into nearby blood vessels. And again, think about a patient with an underlying history of inadvertent weight loss and some iron deficiency anemia at baseline. And that's really, really important here. The next thing is if we go beyond the large intestine to the area of the anus, then we're thinking about something called hemorrhoids. And so usually there's two different types of hemorrhoids. There's internal hemorrhoids and external hemorrhoids. Both of these can bleed. I'd say the difference between these is that external hemorrhoids are going to be extremely painful and internal hemorrhoids are not going to be as painful. And again, we delineate these by something called the pectinate line. So if it's above the pectinate line, it's an internal hemorrhoid, and if it's below it, it's an external hemorrhoid. But these can definitely cause bleeding, especially upon wiping the anus. Usually during defecation, it definitely can cause a lot of blood to come up on the toilet paper. And usually, again, there's some degree of itching and pain associated with this one. The next thing that I want you guys to remember here is for lower GI bleeds, again, there's not a lot of oxidation of the blood, so it's going to appear more bright in comparison to more of a darker appearance of the stool. So it's going to be, again, more hematochezia, more of a brighter appearing bloody stool. All right, so we delineated between upper GI bleed and lower GI bleed based upon anatomy, based upon also the different types of causes, based upon where these bleeds could occur. And we also delineated them based upon their presentation, which is hematemesis melena for upper and then hematochezia for lower. What's another way that GI bleeds could present? Well, they could present pretty bad. Sometimes if patients are losing a lot of blood, whether it's hematemesis, whether it's melena, or from hematochezia, and they are losing pulling blood from their GIT and depleting their intravascular volume, they can drop their amount of hemoglobin. If you're losing blood out of your vascular system, you're going to lose hemoglobin. You're going to lose red blood cells, and even lose some of the iron as well. So these patients can develop a pretty significant anemia. So you're going to want to trend their hemoglobin and say, hey, their hemoglobin is continuing to drop. That could signify that they're having an ongoing GI bleed. The problem with this is that whenever you're losing hemoglobin, you're probably also to some degree losing volume out of your vasculature, because you're bleeding not just red blood cells, you're bleeding volume like plasma, right, into the actual GI lumen. And so your blood volume can drop. The problem with that is I can drop my stroke volume, I'll drop my cardiac output, and then I'll drop my overall mean arterial pressure, the pressure that I perfuse organs with. And if that happens, the patient may not perfuse organs appropriately, and they can go into shock, something we call hypovolemic or hemorrhagic shock. And these are two ways that I want to watch out for. I want to watch for a patient to be, are they hypotensive? Are they tachycardic? Are they pale? Are they cold? Are they clammy? Are they having a really intense like vasoconstrictive response to protect them from this low blood pressure? And do they have a drop in their hemoglobin and their hematocrit? If they do, they have a pretty bad GI bleed, and I got to go ahead and look into this pretty quickly. So that leads to the next step. How do I determine which type of GI bleed I have? And then maybe along the way, can I figure out the cause of that GI bleed? Well, let's talk about that. First thing is I want to differentiate these into two types. Is it upper GI or lower GI? If you see this, I want you guys to start screaming out, oh, this is upper GI, Zach. Okay, I suspect it's an upper GI based upon the presentation. Well, then I got to go down the esophagus, look into there, look into the stomach, look into maybe even the duodenum and see if I see anything. So what we do is we determine the patient this decision to do that based upon their degree of stability in their blood pressure, their heart rate, and etc. If they are hemodynamically unstable, meaning that their blood pressure is low, they're in shock, they're tachycardic, they're really cold, clammy, they're requiring a lot of resuscitation, then we should resuscitate them before even taking them to the endo suite and considering doing an EGD. So give them pack red blood cells, in other words, to get their hemoglobin above 7 or get it up to the point where they're hemodynamically stable. So when we resuscitate patients, we don't go off of a target if they're hemodynamically stable. We go off of, have we given them enough blood that their blood pressure stable, their heart rate stable, and they look okay. If that's the case, okay, cool, then I can go ahead and I can go further evaluate this patient. So if they've now have been hemodynamically stable, then I should do an EGD. That's where I'm going to take a scope. I'm going to run it down. I'm going to visualize the esophagus. Oh, okay, is there any esophagitis? Is there any cancer here? Is there any like Mallory-Wise tears? Is there any esophageal varices? No. Coming to the stomach, is there peptic ulcer disease? Is there some type of Delafoy's lesion? Oh, no. Okay, let me go into the duodenum. Is there, again, a peptic ulcer here, or is there an aortic enteric fistula? I'd be able to visualize that right away. Now, if I do see it, the beautiful thing about this is that I have the opportunity to treat it. So sometimes if it's a smaller bleed, I can cauterize that so I can burn the area where it's bleeding, or maybe I can band off. So banding is really good for the esophageal varices. Or if it's a vessel, I can try to inject epinephrine into the vessel to vasoconstrict it to reduce that bleeding to that area. And so these are all things that I could do to try to stop the bleed, especially if it's in the upper GIT. Now, if I do this and I see nothing in this area, then it's probably not an upper GI bleed, or if it is, I'm just missing and it's intermittent. So then what I want to do is I want to say, okay, I don't see anything right now in the upper GIT. Could it be a lower GI and I'm missing it? So then you're going to go to the next thing, which you're going to go up through the colon. You're going to evaluate the anus. You're going to evaluate the large intestine and see, do I see any area of bleeding here? Do I see a mass? Do I see a really significant area of colitis, suggesting ulcerative colitis? Or do I see an AVM here? Okay, then I got to treat these appropriately, right? Now, if you don't see a lower GI bleed, then you've at this point said, I don't see anything in the upper GIT. I don't see anything in the lower GIT. You could eventually later go back and scope them again, but oftentimes we're going to say that this patient has an obscure GI bleed or an intermittent GI bleed that I'm missing, and I can do other tests for that. So what are some of these things that I could do to find this obscure GI bleed? One of the first things I could do is I could get what's called a tagged red blood cell scan. It's kind of cool. You give them a radioactive tracer, and this tracer is going to then kind of move through the area of the blood vessels. And then if there's an area, especially in the GIT, where that blood vessel is kind of supplying, if it's kind of leaking out or leaking into the lumen potentially of that GI organ, it'll show up. So it'll show up away from where this vasculature is. And so here we can see that there's definitely some bleeding into an area of the GIT. I just don't know where. And that's the downside of a tagged RBC scan. It'll show you that the patient has a GI bleed. It just won't be able to localize as well where that GI bleed is. One of my favorite scans, and I think is very effective, is a CT angiogram. And the reason why this one's good is it can show you, first off, where the vessel is. It can show you the specific vessel of where this is actually kind of extravasating into the lumen. And on top of that, it can tell you maybe potentially the cause. So it's really good at being able to identify the vessel that's bleeding, where it's bleeding, and again, potentially even identify the cause of this patient's GI bleed. The other kind of way that you could do this is there is different angiograms. So you could do a CT angiogram, but you could also do what's called a digital subtraction angiogram. And you take a catheter, you run it into the vessels here, and you shoot contrast. And what happens is it may be filling the different vessels, and you'll see where the blood is kind of leaking into the lumen of the GIT, especially in the ascending colon. So this is a really good test, and you can do this via CT, or you can do a digital subtraction angiogram. Another test that they could do is called a push enteroscopy. So let's say that they're going to do a endoscopy again, an upper EGD again. You could just basically say, all right, I'm going to go a little bit further down into the other parts of the small intestine. Maybe I'm missing it. It's in the jejunum and the ileum. And so you can do a push enteroscopy if you really think that the bleeding could be a little bit further down. Another way that you could do this that is less invasive is you could swallow a pill. Usually these patients need to be a little bit more hemodynamically stable to do this, but just swallow a pill, and what it'll do is it'll run down the GIT and take pictures all along the way. And then it might be able to tell you, oh, I did see something in parts of the GIT, and there it was. Oh, it was a tumor that was bleeding. So a capsule endoscopy could also pick up some intermittent or obscure GI bleeds that you didn't get on the EGD or the colonoscopy. Now, let's say that we go the opposite direction. We have a patient with hematochezia. So bright red blood, there's no melena, there's no hematemesis. I suspect that it's possibly a lower GI bleed. Well, again, if they're hemodynamically unstable, you can't take them to do a colonoscopy because they're just going to be bleeding so much that you're not even going to be able to see what's going on, because you're suspecting that oftentimes in hemodynamic instability, they're bleeding so much, either from their upper GIT or lower GIT, that if you try to go and put the scope there, you won't see anything except blood. So you have to resuscitate them, get a little bit more stable, and then once you've done that, then try to proceed to the actual scope testing. So what would I do here? I would do a colonoscopy if they're hemodynamically stable. I would evaluate them, see if I find the bleed. Oh, there it is. It's from a colitis area. It's from a tumor. Oh, it's from an AVM. Then I can go ahead and I can cauterize it. I could band it. I could use any epi into the area and kind of vasoconstrict it. If I don't see it, well, then I've said I don't see it in the lower GI tract. Maybe it's in the upper GI tract and it's pretty brisk. Okay, I'll get an EGD. If I do the EGD and I see, oh, there it is. I see the bleed. I see it's definitely from the esophagus and it's very brisk, or it's from the stomach and it's very brisk, or it's from the duodenum and it's very brisk. Okay, cool. Identified it. I can cauterize it, band it, or inject it with epi. But if I don't see it, then at this point, I know I don't see a lower GI bleed actively. I don't see an active upper GI bleed, so it's potentially obscure GI bleed. It's intermittent. I'm missing it. So what do? I do the same thing. I get a tagged RBC scan. It'll show you if there's a bleed, just won't locate it. CT angiogram will definitely identify the vessel that's bleeding. It'll identify the location and potentially the cause. A push enteroscopy would also be able to do this as well, but it's going to be more particularly looking into the jejunum and the ileum. And the capsule endoscopy would be a very good test. It's non-invasive. It takes some time, but you would swallow it and it would show you, again, there is a bleed somewhere, and it may give you an idea of the location. The last thing I think that's important to remember, as I showed you that image of the angiogram, the CT, and then there was what's called the digital subtraction angiogram. In patients who are being resuscitated with blood, and maybe they're getting fluids, and maybe they're getting vasopressors to keep their blood pressure up, and they still remain hemodynamically unstable, you can't send these people to EGD or colonoscopy. That's not a good look. So because of that, I need to send them to two different areas. One, as in I need to open up their belly, and I need to find the bleed that way, which is not great. Again, that has a high risk of death and mortality. And you don't want to do the XLAP unless you really, really have to. The first thing that you should do is do an angiogram. And that was that picture that they had. The catheter was running through the artery and it was shooting the contrast and showing you, oh, there's the area of the bleed. The beautiful thing about the IR is that it could show you the bleed, so it could diagnose it. And then you can take and put coils into the area where the bleeding is and stop further bleeding into the GIT. Some people may not be amenable to this though. And if they can't get this, then you need to go to a surgical procedure where you open up the belly and you literally look for where the bleeding is and you stop it that way with cautery or banding or injection, whatever it may be, or potentially even bowel resection. So we've now diagnosed whether it's an upper, lower GI bleed. How do we treat it? It's actually not too bad. So we kind of talked about resuscitation. On a patient who is hypotensive and hemodynamically unstable, you're going to give them packed red blood cells and IV fluids and maybe even vasopressors. But you do it with the goal to improve their blood pressure and hemodynamics. In patients who are maybe a little bit more hemodynamically stable, all you're trying to do is resuscitate them to the point where you give them back the blood that they're losing. So some of the ways that we can do this in a patient who, again, is not hemodynamically unstable. This is more for the patient who is hemodynamically stable. We want to try to maintain a packed red blood cell goal, so giving them a transfusion only to keep their hemoglobin just above 7. The only way we would push it a little bit higher is that literature says that in patients who are having active myocardial ischemia, in other words, they're having an MI, you should push the hemoglobin up a little bit higher, just so that you give more oxygen to that ischemic myocardium. So hemoglobin of greater than 7 is the goal. In other words, if a patient has a hemoglobin of 6 and they have a GI bleed, you give them 1 unit. That'll get them up above or at least equal to 7, and you've done your job. If they're an active myocardial ischemia, so NSTEMI, then you should push it up to 8 and give them 2 units. All right. The other thing is that you're just going to get 2 large bore IVs. The reason why is these are going to be able to give you a good access to get a lot of blood into these patients really quickly. The next thing is, in most patients with an upper GI bleed who I think that they have an upper GI bleed, you should always have a degree of suspicion that, again, the most common upper GI bleed is peptic ulcer disease, Zach said. So I should reduce the risk of them kind of eroding any more of these ulcers, worsening the bleeds in the stomach or in the duodenum. PPIs are usually going to be something that are empirically given to patients with a GI bleed, especially if it's suspected to be upper, just because, again, it'll prevent any further worsening of the GI bleed. If you have a patient with a history of cirrhosis, you should definitely think about esophageal varices, especially in the scenario of hematemesis. If you suspect that they have a potential to have esophageal varices, you should put them on octreotide. It's suggested by the guidelines. The reason behind this is that octreotide will vasoconstrict those splanchnic vessels and reduce the portal pressure and help to reduce the further bleeding there so that you can stabilize them enough to go and treat the underlying cause, which is the varices. So again, transfuse these patients for these goals if they're hemodynamically stable, get good access, give them a PPI, especially if you have a suspicion of upper GI bleed, octreotide only if you think that they have a history of cirrhosis and could be esophageal varices. Then you go and you control the area of where the bleeding is. If the patient is hemodynamically stable enough for you to get an endoscopy or a colonoscopy, great. Then you can go in, you can find the area where they're bleeding, you can cauterize it, you can band it, you can inject epi into it, etc. And you're done. You've treated the source of the bleeding, and then you're just going to, again, maintain this goal, prevent any further erosion, and if they have esophageal varices, it's octreotide, again, until you've banded that esophageal varices. If the patient is not able to get an endoscopy or colonoscopy to locate the bleed and treat it, then you should do an endovascular study. And a lot of these interventionalists will request you to get a CT angiogram to find the location of where the bleed is. Then they'll go in, they'll shoot contrast and say, oh, there it is. I see the bleeding. I'm going to go ahead and embolize this area of where the vessel is bleeding into the GIT. You're done. You've controlled the bleeding source. However, if the patient is not a candidate for embolization, maybe due to the characteristics of the bleeding or some other reason, then maybe in these particular situations, and only then, would you go to a surgical procedure where you'll open up the belly and find where the bleeding is and potentially stop that with cautery or banding or some type of epi injection or resection of the underlying disease segment. But again, usually last line. All right, my friends, that's GI bleed. I hope it made sense. I hope that you guys did enjoy it. And as always, until next time.